giving us some insight, which we'll go back to a bit later on today about the microbiome. So we're going to continue on and we'll go to our second speaker. And the second speaker in this session is Linda Adair, and she is Professor of Nutrition in the School of Public Health at the University of North Carolina. She's currently working on a large-scale longitudinal survey, which is looking at patterns and determinants of growth from infancy through to adulthood. And today she's going to talk about the role of disparity in the origins of obesity risk. Linda, thank you.
Well, thank you very much. It's a pleasure to be here, and I very much appreciate the invitation. In particular, I'm someone who's not studying epigenetics per se yet. I'm embarking on some new studies that have an epigenetic component, but my role today is to really provide perspective on the extent of the problems that we're trying to solve with the perspectives raised here, and the potential for epigenetics to inform strategies to reduce disparities. So when we talk about disparities, we're really talking about great differences, lack of equality. And just to start out, I mean, you've seen some of these representations already, but here's part of the problem we're trying to solve. The prevalence of obesity varies quite substantially in young children. And here what you're looking at is the differences across race, ethnic groups from a very large database in the US, showing how we have quite different levels, starting even in the 0 to 11-month range, moving on up to the 5-year-old, with Alaskan Indians, Native Americans having the very highest rates of child obesity and the lowest rates in non-Hispanic whites. This is seen not only in the US, but globally, and these are data from 26 different low and middle income countries represented in the demographic and health surveys. And so you can see across a wide range of countries that we're seeing more and more children having a weight for height Z-score or BMI Z-score above 2. So what is the nature of the disparities that have important implications for child obesity? Well, if we think about some of those socio-ecological models, on the very outer rim, there are differences in resources. So inequities in health promoting resources in particular, a wide range of socioeconomic factors, wealth, income, education, social status, translate into the disparities in nutrition that we're hearing about here. Things like food availability, seasonality, food insecurity, and then specific aspects of diet quality are very important. And on the energy expenditure side, differences in physical activity, resources, and environment are highly differentially distributed according to wealth, socioeconomic status, et cetera. And then we also have very pronounced disparities in environmental exposures, pathogenic exposures. Often those individuals that are most disadvantaged experience the poorest quality air, water. They're more likely to be exposed to toxic metals. They're more likely to be exposed to microbial pathogens because of issues of sanitation, hygiene, water quality, things like close living quarters. And then there are also differences in stress and social support that may arise from financial challenges, the physical environment, emotional factors, and life events. So what does the fetus actually perceive in terms of all of this? What does the young infant actually experience in response to these very wide differences in exposures? So one factor which is very important in the context of epigenetic mechanisms is nutrition. So this translation of huge economic disparities into maternal stores, how much fat is on the mom's body or how thin is she with limited resources, her current dietary intake of specific macronutrients and micronutrients that have importance, such as the B vitamins and methyl donors and other micronutrients that are associated with child growth. And then a number of aspects of maternal metabolism, such as gestational diabetes, or in fact, the genes that regulate folate metabolism. So these are all highly critically important in the first 1,000 days of life. The young infant and developing fetus also experiences quite wide range of variability in toxic exposures. So smoking, we know, is a really important factor, differentially distributed across race and ethnic groups. As I mentioned before, exposure to heavy metals. I'm doing some work in South Africa, and those populations that live close to mining communities have quite high levels of toxic exposures to things like arsenic and lead. And then there's also concern about endocrine disruptors, and all of these exposures are differentially distributed according to socioeconomic status. In addition, as we're learning more and more, there's differential exposure to growth and metabolic hormones such as insulin and leptin, and stress hormones such as cortisol, according to these large-scale social and economic disparities that ultimately translate into what the fetus actually sees. So the maternal nutrition-related pathways that are of particular importance for our discussion today, I think, reflect both sides of the distribution of nutritional status. On the one hand, we have maternal undernutrition, and we know that underweight, inadequate gestational weight gain, and micronutrient deficiencies, which are very highly prevalent in low and middle-income countries and in lower SES groups in high-income countries, are associated with increased risk of low birth weight, small for gestational age, and preterm birth. Also, micronutrient deficiencies, in particular things like iodine, zinc, and iron, increase the risk of these poor outcomes. And you've seen a graph very similar to this already, and I'm sure it'll come up again, but this is work that Caroline Fall put together, showing how if the mother is unable to supply nutrients to meet fetal demand, there's a whole cascade of metabolic events that involve the kidneys, the liver, the pancreas, bone and muscle tissue, the brain, and the HPA axis that have very important implications for the development of obesity, and particular central obesity. On the other side, maternal excess nutrition, overweight, excess gestational weight gain, dietary excesses are all associated with increased risk of large for gestational age deliveries and macrosomia in the infant. So what do the disparities in these factors look like? Well, again, data from the US Pregnancy and Perinatal Surveillance System, which is a very large database, show us that there are substantial disparities in underweight, shown in blue on the left, with the highest rates of underweight in Asian Pacific Islanders. And on the right-hand side, and note in particular how different the scale is here, we're talking about BMI greater than 25 in close to 60% of some of the population. So very, very substantial disparities in underweight and overweight, which have implications for fetal exposures. This shows you a similar disparities in pregnancy weight gain. In the blue, disparities in inadequate weight gain, and in the red, disparities in excess weight gain. And again, you could see this pattern that is associated with race, ethnicity, but there's a large literature that shows us that once you control for SES differences in wealth, education, et cetera, it's not so much race, ethnicity that varies, but it's really the underlying disparities in social factors that race, ethnicity represents. If we move to global trends, this is showing you that over time, we're seeing a decline in underweight and a fairly dramatic increase in the likelihood of overweight and obesity in women of childbearing years across time. So each of these bars represents a different year, and you can see in the across the bars dramatic increases in overweight in a global context in different parts of the world. The Americas and the Caribbean and Oceania have some of the largest increases in maternal obesity that we see worldwide. Also, disparities in maternal anemia, pregnancy-induced hypertension, and gestational diabetes. Again, with very important implications for child obesity risk. And then global variation in infant outcomes. So we have a very high rate of small for gestational age and low birth weight in South Asia in particular, and in sub-Saharan Africa. Whereas when we're dealing with infant macrosomia or large for gestational age births, these happen much more frequently in China and Latin America. In the US, adverse pregnancy outcomes, including preterm births, macrosomia and low birth weight are also highly disparate. Note in particular that preterm births are highest in non-Hispanic Bloc populations, and the rates of low birth weight are also highest in this race ethnic group. In the postnatal period, you can also see some dramatic differences in patterns of postnatal growth by race ethnicity. And these are data from the early childhood longitudinal birth cohort. And what you're looking at is the odds of overweight according to SES in different groups. And so in general, the odds of overweight diverge at about 9 months. So what's happening in infancy, and in particular, things like breastfeeding and patterns of infant feeding are having an effect early in life for creating this divergence of obesity risk by race ethnicity. And then this shows you work that is part of the Lancet Maternal and Child Nutrition series recently published. What you're looking at here is SES disparities in the prevalence of stunting, which is still highly prevalent worldwide, side by side with overweight and obesity among children under 5. And the difference between the blue dots and the red dots is showing you the lowest and highest wealth quintiles. So you can see in particular with respect to stunting, the rates are very different in low income versus higher income populations. The disparities in obesity are not quite as wide, but what we're seeing is that that is changing quite dramatically. The burden of overweight is shifting to the poor in low and middle income countries. Historically, traditionally, high income countries, we find obesity prevalence to be much higher in disadvantaged groups, whereas in low and middle income countries, obesity was found mainly in upper SES groups, but it's now becoming a problem among the poor, and the fastest rates of increase in child and adult obesity are among lower income groups. And this is very important in the context of disparities because it's those low income groups that also have all of the other environmental risk factors that I've mentioned. They have the higher exposure to toxic substances. They're more likely to have low quality diets. So we see this convergence of risk in the lower income groups, even in low income countries. And this is a graph that shows you that's the evidence that the burden is shifting to the poor. So this is plotting the annualized difference in overweight prevalence growth rates, how fast obesity is increasing in all of these different low and middle income countries around the globe. And a positive difference in the prevalence growth rate indicates the lowest wealth quintile had a higher rate of prevalence growth. So we're seeing this slope in all of those countries that are above 0 are showing this dramatic increase in obesity among the poor. As we move also to the postnatal period, there are quite dramatic differences in breastfeeding. And as we just heard from the last talk, the quality and quantity of breast milk that infants are fed is really critical for their development, and the fact that there are differences in the composition of breast milk according to maternal weight status is a concern. Depending on the source you use, you find quite dramatic differences in the estimates of prevalence of breastfeeding. The U.S. pregnancy and perinatal surveillance data show less disparity than, for example, if you look at low-income populations. On the right-hand side, you see that only a little over half of non-Hispanic low-income white moms initiated breastfeeding. Only 42% of low-income African-American moms initiated breastfeeding, and the average duration of breastfeeding is only about 3 months in that group. There are also substantial variations in infant and toddler feeding, and multiple aspects of infant and child feeding reflect disparities in race, ethnicity, weight status, and they play out in terms of initiation and duration of breastfeeding, the timing of complementary foods, and the types of complementary foods that infants are fed, including fruits and vegetables, salty snacks, sweetened beverages, etc. So if we can take almost every one of those different types of disparities, and what we're finding in the literature and what we're hearing about here at this conference is an epigenetic effect. So if we look at maternal glycemia during pregnancy, there's evidence of alterations in methylation profiles in the adiponectin genes. If we look at parental overweight in terms of both mother's overweight and father's overweight, there's hypomethylation of IGF-2. The maternal diet has implications for, in terms of carbohydrate intake, famine conditions, which we'll hear more about tomorrow from Ari Stein, vitamin and mineral intakes, for example, work that's being done in India on B12. So if we take each aspect of disparity, what we're now finding is that there is a mechanism associated with epigenetics that can influence that. Now, I'm going to leave the details of that to others that are here because that's the focus of the research. But I just present this as a way of showing you that every aspect of disparity, which we can note, now has an associated pathway to try to link that disparity biologically to an obesity-related outcome. So stress, environmental exposures, maternal depression, breastfeeding, all of which differ quite substantially according to SES, race, ethnicity, where you live in the world. There is now a way to try to explain and understand the biology of how those disparities translate into obesity risk for the child. So what are the implications? One of the things that I want to raise is this notion of mismatch. The epigenetic changes that we're talking about are really examples of developmental plasticity. They're adaptations that enhance survival in the environment to which the organism is exposed. So the mother provides information about the environment to the developing fetus. And that fetus develops a set of adaptations that are responsive to the cues about the environment translated from the mom. And those cues are thought to result in a developmentally agile individual who copes well with the circumstances that they've been exposed to in utero. And the idea here is that those adaptations are also anticipatory. That is, they should be well suited to the environment that the individual will experience in the future as well. And this is work that is largely been done by Bates and Gluckman and Hansen and others. However, if the environment that is experienced postnatally is not what was predicted prenatally, we can have an organism that's maladapted and at increased disease risk. So for example, with poor maternal diet, inadequate nutrient stores, or placental factors that limit transmission of the nutrients to the developing fetus, we can get fetal nutritional insufficiency and all of the associated metabolic differences that characterize undernutrition, altered cell numbers, altered regulatory processes, altered epigenetics. When the individual is exposed to dietary excesses or sedentary behaviors, an organism that's programmed for undernutrition may be in fact maladapted and hyper-responsive to nutritional adequacy or excesses. So as an example, if we look at the offspring of malnourished Indian mothers, and this is work that has been done by Ranjan Yagnik, on the left you see the body composition of a white Caucasian baby that weighs 3,500 grams, the average birth weight. And you can see that in this infant, their fat stores are about 10%. In the Indian baby of average birth weight, which is about 2,700 grams, you can see that fat is about 20% of the body, and muscle mass is 10%. And so Ranjan talks about this as the thin, fat Indian baby. So this is a baby that in utero developed a limited muscle mass and is more adipose. And if you think about the probability of this child being diabetic later in life, it makes sense. They've got reduced skeletal tissue mass and already increased adiposity at birth. So this child was well adapted in a way, survived a maternal environment of constraint, but then later as it increased risk. And what we see in India very classically is that the conditions which were apparent 30 years ago, for example, among today's moms, were such that low birth weight is highly prevalent, child stunting is highly prevalent, under 5 mortality is high, but today we're seeing a dramatic increase in maternal overweight and obesity in Indian moms. More and more are obese. We're seeing 11 to 12% obesity in New Delhi, 14 to 17-year-olds. 25% of adult women are centrally obese, and we're seeing increased rates of diabetes. So India is thought to be kind of a classic case of mismatch where that young, undernourished baby is growing up in an environment that's much more associated with obesity. What about children? What about child obesity? Most of the studies of mismatch have focused on the longer-term effects, but can mismatch help us understand rapid infant weight gain? So just as a quick example of maternal constraint, we often see lower birth weight in infants born to first-time mothers, but firstborns who are well-fed experience rapid postnatal weight gain. This, in a way, is an example of mismatch. They've experienced prenatal constraint followed by rapid postnatal growth. And so they were prepared for a plane of undernutrition but experience overnutrition. And just the quick result that I'm going to show you comes from a cohort study that involves a collaboration among individuals with birth cohort studies in 5 low and middle income countries around the world. And low birth weight occurs in around 10 to 20% of the infants in these 5 countries, Brazil, Guatemala, India, Philippines, and South Africa. As yet, in these populations, overweight was not highly prevalent, but we're seeing the development of overweight, in particular in the South African population, and then in Guatemala and India. The participants are older, and so young as adults, we're seeing a lot more overweight and obesity. So what's interesting is we can look at the prevalence of overweight in those who are low birth weight in the population, and as yet, the prevalence of overweight in those who are low birth weight is not very high. But what's interesting is that low birth weight in general is associated with lower risk of obesity. But in firstborns, there is an increased risk. So in a way, this is an example of maternal constraint. Those firstborns were undernourished in utero. They have very rapid postnatal growth, and they're the ones that are overweight or obese at age 2. So this is just a quick illustration. There are other studies following low birth weight or small for gestational age infants that are deliberately fed to get them to catch up, and we're seeing increased risk of obesity with catch-up growth. So those may be representations of this kind of mismatch of an environmental adaptation early on that proves to be somewhat maladaptive. So just then to summarize and conclude, there are wide disparities in SES, physical environment, psychosocial factors, and stress that contribute to substantial differences in fetal exposure to nutrients, toxins, hormones, and other regulatory substances. And these disparities affect fetal and infant growth and susceptibility to later obesogenic factors through epigenetic as well as other pathways. Elevated risk of child obesity may result from these prenatal undernutrition as well as nutritional excesses. The risk may be greatest when the fetus is adapted to a maternal environment that differs from the environment faced as an infant and young child, and a greater understanding of the pathways through which the disparities that we see on the broader level translate into the biology that's associated with obesity risk, I think has the potential to eliminate the adverse effects of these health disparities. Thank you.